Hi, these are the results of the and responses of the post assessment quiz that I did on Friday. So let's start with question number one. The BCR gene is present at chromosome 22, and indeed, most of you had the right response. That is true for ABL BCR. Importantly, you will be asked questions for other disorders as well. But 5 guys got it false. We got a total of 15 responses. Accelerated phase in CML had greater than 20 percentiles. This is wrong because it would make it a blast crisis. Majority of guys got it right as well. Imatinib is continued indefinitely in responders of CML. This is very important and most of you got it right. The answer is true because if you discontinue, it will go into blast crisis. Decrease in spleen size is a poor predictor of response in CML. Most of you got this answer wrong. You answered it true, right? So decrease in spleen size is good, right? If CML has splenomegaly and if the thing would respond to treatment imatinib, then the spleen size would go down, right? So almost 40% of you got the answer wrong. Juvenile CML leads to an increase in HbF, right? It is a form of CML which happens in young children, and here HbF is high. It's a fact-based MCQ, so nothing to, nothing much concept about it. ALP is increased in polycythemia vera and multiple myeloma. This is a wrong statement. ALP is normal in multiple myeloma, while ALP can be anything in polycythemia vera. Now this is very important, but most of you got it wrong. 814 is most common translocation in multiple myeloma. This is a wrong answer. 414 and 416 are common. So it was a distractor, but it had been tested on NEAT and you got it wrong. Lytic lesions are a minor criteria in Dury-Salmon staging, and this is right, and most of you got it right as well. Important, learn Dury-Salmon staging, but it will be tested on NEAT. Anemia is most common presentation of multiple myeloma. Most of you got this thing wrong because bone pain is the most common presentation of multiple myeloma, and patient will say that he is having a lot of bone pain. Okay, you will discover anemia incidentally. Younger patients in multiple myeloma should undergo stem cell transplant. Most of you got it right, and this is indeed the correct answer. An older patient should be given chemo only. Hydroxyurea is a common therapeutic in multiple myeloma. Most of you got it wrong. Hydroxyurea is not used in multiple myeloma. We use melphalan, prednisolone, and bortezomib. Smoldering myeloma and MGUS doesn't need any treatment. It is right. It's smoldering myeloma and MGUS don't have any active lesions, right? MGUS, even the proteins, Ig proteins don't meet that level, while in smoldering myeloma, the proteins, M protein reach a required level, but there is no organ damage, okay? IgA is the least common spike in M component in multiple myeloma. Most of you got it right, okay? Most common is IgG, then A, then M, then D. Okay, so D is the least common. Waldenstrom microglobulinemia has high IgG component and hyperviscosity symptoms. So this is wrong, and most of you had the right answer because it is due to IgM. Multiple myeloma can lead to hypoglobulinemia as well. It is right. Multiple myeloma though has M spike, but it can sometimes cause hypogammaglobulinemia due to ineffective proteins and recurrent infection. Bortezomib and lenalidomide commonly used in CML. So here it is false, right? Because they are commonly used in multiple myeloma. Secondary polycythemia is also known as gas box syndrome. Most of you got this answer wrong. Okay. because second, it is relative polycythemia is known as gas box syndrome. It is due to dehydration. It is not secondary polycythemia. Both thrombosis and bleeding can occur in polycythemia vera. This answer is right. Why? Because thrombosis occurs due to hyperviscosity and bleeding occurs due to increased histamine release by basophils, which can cause peptic ulcer disease. Okay. 1/3 cases of polycythemia vera will go on to transform to acute leukemia. This answer is wrong. This is true for CML. Thrombosis in polycythemia vera occurs due to high RBC count. This is right. This answer is right. Okay. In essential thrombocythemia, it will happen due to high platelet count. JAK2V617F is found in all myeloproliferative disorders. Most of you mark this answer wrong because it is not found in all myeloproliferative disorders. It is indeed found in essential thrombocythemia, polycythemia vera, but it is not found in CML. Okay, CML we have BCR-ABL gene. Phlebotomy is treatment of choice in polycythemia vera. Yes, this is right, and most of you got it right as well. Aspirin and morphine can be given to prevent thrombosis in polycythemia vera. This answer is wrong. I will explain why. It is the thrombosis happens in polycythemia vera due to RBC accumulation, right? Aspirin, warfarin are antiplatelets and anti-clotting agents. So once you have thrombosis, you can give to prevent it, but they cannot be given to prevent thrombosis. We generally use hydroxyurea or others. Splenomegaly is common in essential thrombocythemia. It is there, but it is not very common. That makes it different from polycythemia vera or CML. Okay, so this answer is wrong. CLL commonly present in young people. You got this answer wrong. It commonly presents in old people. Okay. Ruloxatinib inhibits both JAK1 and JAK2. Yes, most of you got this answer right. Thank you.